Hello. Thank you for joining us for a live Facebook Q&A. My name is Dr. Eric Moore, and I'm a head and neck surgeon at the Mayo Clinic in Rochester, Minnesota. Joining me today is my patient, Heidi. Heidi and I produced a series of videos on parotid tumor surgery. Those videos can be found on the Mayo Clinic YouTube channel by searching for ENT Parotid Tumor Guide playlist. I have invited Heidi here today as my guest to answer questions regarding pre- and post-operative parotidectomy surgery. We will be taking your questions throughout the broadcast, so make sure to post your questions in the command section below. Heidi, thank you so much for joining me. What questions should we discuss with our audience today?
Thank you, Dr. Moore, for having me. So I think one of the things that I really wanted to stress again is how important it is for patients to find a skilled and experienced surgeon as they're going through this process. In my view, that is probably the most important thing for patients. And as you have explained to me, it's really important that this surgery is performed correctly the first time. So can you explain for the audience why it is so important that this surgery is done the right way the first time?
Yeah, exactly. So parotid surgery, and maybe all surgery, we always say the first time is the best time to get it correct and to get it right. And one of the problems is that if you have to go back for revision surgery, it's always more difficult because the anatomy gets distorted, we say. Tissue planes get sort of glued together by scar tissue and are harder to separate. It's harder to protect delicate nerves and blood vessels in a revision setting. So your best opportunity to do a surgery properly is that first time. And if you have to go back and redo something or go back because one of your margins is positive, meaning some tumor was left behind, then you put the patient at an increased risk of complications that they might not have if it had been done the first time completely. So that's one issue. And the other issue is experience. We all get better at things by doing them over and over and practicing, and those rules of repetition makes us better at something technical really apply to surgery. And it's difficult to repetitively practice parotid surgery because it's just not that common. At a place here where we see a lot of patients from all over the world with parotid tumors, we get the benefit of being able to have a lot of repetition and a lot of hours doing this surgery, which just isn't available to someone in a smaller community or a more remote area who may be a technically excellent surgeon, a very smart person, but just hasn't had the opportunity to do it over and over and over. So I always tell people, it's a complicated surgery, it's delicate, things usually go very well if it's performed correctly. Usually you only have to go through it one time if it's performed correctly. But if you talk to your surgeon and they say, I've done a couple of these this year, or this just isn't very common for me, I would politely ask for a second opinion. And most surgeons will be very amenable to doing that because they might not feel all that comfortable performing something complicated.
So I think a lot of the patients, wonder, how do I know if somebody has this level of experience that you're talking about? And so, for a patient, we don't really understand this world. So in your view, how many surgeries should a surgeon be performing per year to be considered experienced enough to handle a parotid tumor?
It's a little bit of a broad answer and a broad question, and there's a big range. A very experienced parotid surgeon might have performed over 1,000 or 2,000 parotid surgeries over a 10-15 year period. But also someone very good at parotid surgery might have performed 100 to 150 parotid surgeries. In residency training, we have benchmarks for how many surgeries you need to do to become proficient. And in parotid surgery, it's around 30 to 40 surgeries over the period of residency training to become proficient. And I really think a surgeon probably should be performing more than 20 surgeries a year to maintain proficiency in something like that. And the easiest way to tell that is just to ask your surgeon, is this a common surgery for you? How many of these have you done? People ask me that every day. I don't feel offended by that question or put off by that question. I welcome the question because it's an opportunity to talk about why repetition is important, why it's important to have someone with some experienced judgment making, because there are some judgments that have to be made intraoperatively for the surgery to go well. And then they'll tell you if they feel comfortable or uncomfortable with their level of experience.
And I think, like you and I have talked about on some of the other videos, that one of the other ways that patients can determine whether this surgeon has enough experience is just by asking questions and listening to the responses that they are provided. And I know we have spoken about how important it is for a patient and a surgeon to develop this working relationship where you're, on the same team and you're trying to, get to the point where you have this positive outcome. And so as far as I'm concerned from a patient, the things that help me build trust and respect for a physician is someone like you who listens to what I have to say or who thoroughly explains things so that I understand and have the facts available to be able to render good decisions for myself. So on the other side, as the surgeon, what do you feel like patients can do to help foster this working relationship?
I think the things that you've emphasized as having a relationship and having a trust are very important on the patient side and very important on the surgeon side. And the surgeon also wants to feel like they have trust and rapport with that patient. So the preoperative visit is designed to discover the problem, decide what needs to be done, but a lot of the preoperative visit then shifts into informed consent, talking about what's going to happen, building that rapport of the patient knowing that the surgeon's going to do their utmost to make sure everything goes well, and the surgeon knowing that the patient trusts them and has that trust and isn't questioning every single thing they're doing. If that trust breaks down, I think it causes some anxiety on both sides. In addition, I think it's important for the patients to ask questions, because I might tell a patient something that I think is important for them to know. I might explain it in a way that I think they understand, but they might not understand what I'm saying, or they might not agree with what I'm saying, or it might not have the import to them. And so if they ask questions to me, then I feel like I'm really getting to the heart of what they need to know and alleviating some of their anxiety and making sure that they understand the process, what's going to be involved, what's going to happen to them after the operation, what we're going to need to do for post-operative care.
And I think there is always going to be some level of anxiety with this surgery. It's a very difficult surgery to get through. So I think one of the other messages for patients is that if they are anxious and they're stressed out and this is a really difficult period in their life, that's totally normal to feel that way. And you're going to have ups and downs, and some days are going to be better than other days. But I really feel like this is such a critical decision to make with your surgeon, because the level of anxiety you have, I think, is directly tied to that level of trust that you have in your surgeon. Mm-hmm. And really, going into surgery, I had complete peace of mind that you were going to be able to handle whatever situation you might encounter. And that is so critical for a patient. I can't thank you enough for that. And I think that, if you do develop this working relationship, it really goes a long way in alleviating some of that anxiety before surgery and also after surgery. I mean, for me personally, I don't worry about having a recurrence or never even really think about it, because I'm so confident that you handled things and made the best decision for me. So I think that, again, this is why, to me, this is such a critical component of this entire parotid tumor journey.
I think that some of the things you touched on there, though, as far as having anxiety, worrying that something bad is going to happen down the road, worrying that a tumor is going to come back, worrying that things are going to go poorly, there needs to be some coping mechanism and alleviation of anxiety for things to go well. I feel like anxiety actually has a very negative import on patients' health, and it doesn't help their immune system, doesn't help their sleep. It can actually have physiologic repercussions. So a lot of times in that discussion and post-operatively, a lot of what I'm doing is trying to alleviate that anxiety. We all have unknown things in the world that are going to happen to us, but constant worry about them probably isn't going to make them happen less often or make us feel better or function better. And so the ways that we can deal with that anxiety and cope with it, I think, are very important.
Okay, well, so now that we've kind of talked about selecting a surgeon, let's move on to the actual surgery itself. So I think another key issue for a lot of patients is centered around this idea of what kind of incision am I going to have, because obviously the surgery is performed on a very highly visible area and you can't cover this treatment area, so that is something that concerns patients. And because it's on your face, I think a lot of people want to have the smallest incision possible, which it is possible to do that, but I think that sometimes patients might not consider all of the repercussions of just simply focusing on having a small incision. So can you talk a little bit about what are some of the factors that they should be thinking about as they're trying to decide for themselves, what kind of incision am I going to have?
Yeah, this is a very timely and important topic. And I feel like medicine and surgery is a consumer-driven enterprise, and the response of the surgical industry to consumerism has been to try to do more minimally invasive surgery and make smaller incisions and do things through these smaller incisions, which has a lot of repercussions both positively and negatively, I think. So the parotid gland sits in a very cosmetically visible area of the body. It sits right on the side of the face. And obviously, our facial expression and our facial appearance is what we present to the world the most often and is vitally important to many people. And so when people undergo a surgery, they're worried, am I going to be disfigured? And am I going to have scarring? And what am I going to look like afterwards? And the initial reaction to that in this world of parotid surgery was to try to better hide that incision in the natural skin creases of the face. Our eye is designed to pick up lines in certain orientations and consider that normal, and then pick up lines against those orientations and consider that abnormal. So parotid surgery originally was done almost through straight incisions straight down, but that's not a normal scar. And the initial reaction to that was to curve the incision around the ear and into skin creases. That hides the incision very well, even though it's not a short incision, because the incisional scar tends to lie in these transition areas where we expect to see some shadows and lines. Going further, we've reduced the size of our incision to smaller and smaller and smaller incisions, and have placed it further back behind the ear, and that does a very good job of making that incision almost invisible to the casual observer, even right after the surgery. But every small incision, the smaller you make the incision, the more you limit what we call your surgical exposure and your vision, and you have to do more technically difficult things to be able to deliver the parotid tumor intact and see the nerves well through those small incisions. Very experienced people who are very accustomed to that can do that very well most of the time. It's hard to do. There's a learning curve to it. Less experienced people are challenged by it. But one of the things I'd like to point out to people is that the incision and the incisional scar, in my experience after doing this many years, 5 months down the road, 6 months down the road, is not one of the big issues with patients. And so don't get too hung up on the length of your incision, and don't try to handcuff the person doing the procedure by making them work through a very small incision if they don't feel comfortable doing it that way, because ultimately that incision is going to look very good. A perfect example is that some of these tumors are extremely fragile, and you just cannot put much pressure on them with having them rupture. Or some of the tumors are not very well defined, and it's hard to appreciate the boundaries of them. And if you're working through a very tight space with very limited visualization, and then you spill that tumor or don't get the entire thing out, what you were shooting for, that perfect outcome, is now really compromised, and the incision now may become very much a minor point compared to the repercussions of the other things that happened. And so it's not always having the smallest incision is what guarantees the best cosmetic outcome in the procedure.
Okay. I think some of the other things that maybe people aren't prepared for when they have surgery is, how is this area going to feel afterwards? And so there are a lot of patients who feel like maybe their mobility in their neck is limited, or it's tighter than it used to be. There's pains, there's other things that they didn't have before surgery. So what would contribute to that? And is that something that's going to go away, or does it depend on each patient and their circumstance?
You, having undergone a parotid surgery, are probably better equipped than anybody to talk about what it feels like at different stages. But I do feel like most people say, as the incision heals and they get over the initial operation, it's swollen, and then it starts to become tight. And the body heals almost all wounds by contracture and developing some scar tissue. And most people feel like that is at the least a little bit of tightness, and sometimes a constricting feeling around their ear, their face, and their neck. And that's actually a normal process. It's not that something's going wrong. It's the body is generating the normal scar tissue and healing that wound. It gets a little bit worse before it gets better. So I do feel like time helps that, and probably just moving the neck and mobility and sometimes therapeutic massage and stretching alleviate a lot of that. But in the initial period, the wound starts to feel tight. And the other thing that it does is it starts to feel numb. Right? Because when you lift up the skin, even if you do it through a tiny incision, and elevate the skin over the parotid gland, which you have to do to get any part of the parotid gland out, you are severing tiny, fine, invisible nerves that are sensory nerves that end up in the skin to touch. We have a lot of touch sensation in this area. And those nerves are not the facial nerve that moves the muscles to the face. They're the sensory nerves around the parotid gland. And that's typical of any incision anywhere in the body. You lift up the skin, it's going to be numb until those things regenerate. And they do regenerate. We were just having this conversation earlier. How long did it take? Up to 3 years it took for the sensation to finally feel normal. I always tell people this is going to be the last thing to recover in you, that touch sensation in your cheek. We have a really good question from the audience regarding that, sort of dovetailing on that incision. It's that, can a simple excision of the tumor be done versus a superficial parotidectomy? And here we have to talk about the sort of anatomy of the parotid gland and different kinds of tumors that can occur. And along the lines of the incisions getting more minimally invasive and smaller, another thing that's become very popular is to do more finite, fine incisions of benign parotid tumors, taking out just the tumor and the capsule and sometimes a little bit of gland around it, then rather than removing the whole superficial lobe of the parotid gland or a major part of the parotid gland. So the parotid gland is this salivary tissue that's kind of conglomerated around the facial nerve. And we talk about a superficial lobe and a deep lobe that are divided by the facial nerve, but there's actually no distinct anatomic boundary between those two parts. There's just parotid tissue above the nerve, parotid tissue below the nerve, and parotid tissue surrounding the nerve and those branches. Traditionally, when there's a parotid tumor in the gland, it's going to be in that superficial part more often, in the part above the facial nerve, because more of the gland is above the facial nerve. So by percentages, about 80% of the gland is on top of the nerve, 20% is below it. Most of the tumors then are going to occur on top of the nerve than below it. They're not more likely to occur in one part or the other by tumor type, it's just that more tissue is above the nerve. To get those tumors out, we like to see the facial nerve usually, so we lift up a portion of the parotid gland, find that nerve trunk, and then trace out those branches. And in the sort of traditional surgery, the superficial portion of the gland, which encompasses about 80% of the gland, is removed to ensure that the tumor is encapsulated and can come out completely. Is that necessary to do to remove the parotid tumor safely? Most of the time, no. In fact, as long as you get the whole tumor out encapsulated within its capsule, that is enough for most benign parotid tumors. Malignant tumors are a different situation because they have more chance of spread and lymph nodes are involved and we have to remove more gland. But for most benign parotid tumors, removal of just the tumor and a little bit of gland tissue around it, maybe as a cuff, as a safe margin, is adequate. But several things have to happen to make that successful.
Okay.
First, you have to know that that's a benign parotid tumor. Many times I see patients who their tumor acted benign by behavior. It was thought to be benign. It might have even been needle biopsied as likely benign. And the tumor was taken out just as the tumor with no gland around it and just the capsule, and it turned out to be a malignant tumor, and the pathologist is asked to say, is the margin clear? And what you're asking the pathologist to say is there normal tissue at the edge of that gland, so you can ensure that the whole thing has been removed. If you just take out the tumor itself and no gland tissue around it and do the minimalistic approach, and the tumor turns out to be malignant, by definition your margin's going to be positive. And now you have this conundrum of, should I go back, take out more parotid gland tissue in a revision setting, which is more complicated to get an adequate margin. So I discourage minimalistic just tumor enucleation in the situation where we don't 100% know that that tumor is benign, or at least we're going to be able to tell that during the operation so that we can adjust accordingly and not have to go back into that wound again to do an adequate operation. Secondly, the parotid tumors are not all just a single spherical ball. They have irregular surfaces and little appendages on them and parts of the capsule that's very thin. And if you do just an enucleation, I think you are more likely to potentially rupture that capsule. So you have to be very careful doing that and very meticulous. And you're more likely to leave some of those appendages behind and possibly have a higher chance of recurrence. This is under heavy investigation. The way you do that is you do a bunch of these and look back and see how many recurred, and the answer's, I think, still inconclusive on that. But you just have to have a unique situation and the right situation to do an enucleation. And I still think taking out a little more parotid tissue around the tumor is the safest thing for the vast majority of practitioners to ensure that they don't have recurrence.
Okay, so I think you mentioned this kind of in passing, the positive margin. So can you just explain what a positive margin is, and then what kind of follow-up treatment is then required if
Sure.
there is some sort of positive margin?
It's a hallmark of tumor surgery, both benign and malignant cancer surgery, that complete removal is better than partial removal or leaving anything behind, and complete microscopic removal, meaning you didn't even leave any microscopic tumor behind, is the best situation. To ensure that surgically, what you do is you take out the entire tumor and evaluate all the edges circumferentially, and those are called the margins. The margin is the edge of what was removed. And if the margin, the edge of what was removed, and consequently the edge of what was left behind, is right on the tumor, that's going to be a positive margin. I mean, there's no way to 100% confirm microscopically that all of that tumor has been removed. And if the margin is normal tissue, even a small amount, even a microscopic or sub-millimeter amount at the edge of the capsule, you can be more confident that the entire tumor was removed. So when you're dealing with malignant tumors, certainly, and even a lot of benign tumors, and you do surgical removal, whether you need to do any more treatment hinges on what type of tumor it was there spread, and was the margin clear. And if you can't microscopically determine that the margin was clear, meaning you had clear normal tissue right at the edge of what was removed, then the question becomes, should we go back? Should we get a negative margin? Because a lot of times if you leave tumor behind, you have to treat that some other way via escalating your radiation therapy dose, giving a higher dose, or giving radiation therapy where you might not have before, or relying on some other treatment like chemotherapy or immunotherapy. And in general, if we were going to generalize, tumors where the margin was not clear and tumor was left behind do worse. And so it's always the goal to get a clear margin. Now, the margin terminology gets confusing to people because a positive margin doesn't mean positive in the good sense. It means there was tumor there.
Right.
So we speak almost in reverse in pathology terms. A negative margin is a good thing. That means the edge was clear. And a positive margin, meaning there were tumor cells there, positive tumor cells there, is a bad thing, and we try to avoid that.
Okay, so we've talked before about how, as a surgeon, you are making hundreds and hundreds of decisions on behalf of the patients during surgery. And I think one of the things that you've said has helped you make those decisions is this frozen section pathology that is available at the Mayo Clinic. So could you explain what the frozen section pathology is, and then how that helps you as a surgeon make decisions?
Ideally, you would like to have confirmation of that margin right then and there at the time of surgery while the patient's still asleep and the wound is open, so that if you had to do something else, make an adjustment, go back and take more tissue, that's the ideal time, that first time to do it. And so the challenge is getting accurate pathology data at the real-time time of the operation. And this is a very difficult, labor-intensive process, which is why it doesn't work well in every single setting. Frozen section pathology, the frozen section part means that the pathologists freeze the tissue so that it's rigid right there at the time of the operation, can micro-slice it, put that micro-slice on a slide, stain it, and look at it, and give us a reading information right there at the time of the operation, both on what is the definitive diagnosis and is the margin clear. Those are the two ways that we're using them most often. And so that has been perfected at certain institutions, but by definition, to make that viable, you have to have a high volume, because it takes a lot of labor and time and resources, and that only becomes practical if you're using it a lot every day. But in addition, it's a real art. It takes the pathologist thousands of hours to get good at reading that frozen section pathology, because they're doing it on what's called a monochromatic stain. When you look at tissue, you want to tell the different cell types apart, usually by they stain with different colors and different shades, and that gives the pathologist a range of definition. But in frozen section pathology, the only stain that's really practical is a one-color stain, so they have to be very good at determining different shades of blue and what that means, and that takes them years of practice. We're fortunate that we have very experienced frozen section pathologies, but we tell patients we kind of live and die by our frozen section pathology. They tell us yes, the tumor is what you thought it was, you've done the right thing. No, the tumor is not what you thought it was, so we have to adjust accordingly. No, your lymph nodes here have tumor where you didn't think they did, or no, that tumor margin that you just gave us is actually not the real edge of the tumor, you need to go back and take more. But the ability to make those determinations prevents us from having to do as many tests and studies beforehand, but it also prevents us from having to go back to the operating room a second time.
Okay. So one of the other things that a lot of patients, wonder about with this surgery is, the ear feels, not the same after surgery, and a lot of people feel like, did they move my ear during surgery, or what happened? So is that something that could occur, or does it just feel like that to patients, that somehow their ear is in a different position than it was before?
It really happens. And so the earlobe is not anchored to the skull or in a constant position. It's soft tissue. And when we make incisions around the ear lobe, or if we change the amount of tissue that's sitting immediately beneath the skin around the earlobe and have an indentation, and that scars, that can change the position of the earlobe and make it more retracted, or slightly pull it down, or sometimes make it more protuberant. The whole ear doesn't really change positions. It is fairly anchored to the skull, but the soft tissue at the bottom of the ear can distort or move after any incision that occurs around there. So this can happen in facelift surgery, it can happen in parotid surgery. And one of the things that I like to point out to people, and I learned this from experience because I had a patient one time who said, "Why did you move my ear so much?" And I'm like, well, certainly didn't try to, and I don't think I did. But everybody's ear doesn't sit at the same position on their head. If you look at thousands of pictures of people, you'll find that their ears are actually at slightly different levels. But as you start to pay attention to this more and more after your surgery and look at it a lot, you may just realize that. So I do like to point that out to people, that sometimes there is some asymmetry there already, but it can change the position of the earlobe after surgery. We put the skin together right where we took it apart and very meticulously closed it, but that doesn't mean that it wouldn't scar or change a little bit in the healing period.
Okay, so I think another thing about surgery that kind of scares patients is this notion of being put under anesthesia, because for some people, myself included, this is the first time I ever had surgery. So that, and you don't really get a lot of time to meet with the anesthesiologist prior to surgery like you would with your surgeon. Mm-hmm. So what advice do you have for people who are afraid of going under anesthesia for this procedure?
A lot of this, again, is it's an unfamiliar thing and the fear of the unknown. I would reassure people again that most anesthesiologists, or all anesthesiologists for the most part, have the patient's best interest at heart. They want it to go just as well as the patient wants it to go well. Ask some questions. You do see the anesthesia team before the operation, at least for a short period of time, and they usually come in and talk to the patient and ask them some things about themselves, make sure they know their medical history. If there's something in your medical history that you think is very important, definitely point that out to the anesthesia team before the operation, and ask questions before you go to sleep to make sure that you're comfortable.
What kinds of things in your medical history would be important for them to know? Is it whether you're on medications or supplements or things of that nature, or what should they be telling them?
So all surgery involves making incisions, then going across blood vessels and relying on the body's ability to clot those blood vessels to prevent bleeding. So a lot of people these days are on blood thinners to help their heart and to help with vascular flow. And so if you're taking a blood thinner, make sure your surgical team and your anesthesia team knows that. Sometimes we're taking things that we don't know are blood thinners, but are actually blood thinners. So a lot of supplementation, vitamins will affect clotting, and so it's a good idea to have that discussion and make sure people are aware of what medicines and vitamins and supplements you're taking. And other things, surgery is a very stressful event, not only on the patient, but on the heart and the lungs and the body. So it's like running a fast mile for the body, and so any problems with patients' heart, blood pressure, breathing beforehand, the surgical team should seek that out, and the anesthesia team should seek that out, but it's vital that both sides communicate that.
Okay. And I know this can vary depending on where a patient has their treatment done, but how often or how long do patients usually stay in the hospital, or how long can they expect to stay in the hospital, or do they go home the same day?
Historically, it's getting shorter and shorter and shorter. And parotid surgery is a surgery that can be done safely as an outpatient. It's typically an overnight surgery here, but it can be done safely as an outpatient. Listen, these questions are extremely helpful. The patients that I see come in and say, thank you so much for making these things available to us. So you provide an extremely valuable service. I thank you. And if we have questions that we didn't get to, then we will try to get to them if you send them to us through the Facebook page. Thanks very much for your attention, and we appreciate you paying attention during this presentation. Have a great day.